Hello, let's discuss scleroderma. Leading off, I would like to talk about some vocabulary, some classification to make sure we are all on the same page. There are two types, big subtypes of scleroderma. There's systemic and localized. Now, localized scleroderma is confined to the skin. You do not see visceral involvement. Systemic scleroderma, you do see visceral involvement, and we can further subclassify systemic scleroderma into limited systemic sclerosis, in which typically it's only really the hands, you get some Raynaud's, maybe the esophagus is involved. And then there's diffuse systemic scleroderma, which is way worse. The heart, the kidneys, the lungs, they can all get involved in diffuse systemic scleroderma. So two big types, systemic versus localized, and then systemic has some further classification. So what is scleroderma? The word literally means tough skin. It's a chronic disease that plays out over years and years. And it's also an autoimmune disease. It's a connective tissue disorder in which there's way too much collagen getting thrown around by fibroblasts. And so collagen creates the sclero part of scleroderma. It thickens the skin, it thickens vascular walls, it thickens internal organs. And as a result, due to the different organs that get affected by collagen deposition, there's an extremely variable phenotype to this disease. So it can be quite a diagnostic odyssey for patients. Therefore, you really ought to care about recognizing the many telltale signs of scleroderma to help patients pick this up as early as possible. Localized scleroderma is also called morphia. And localized scleroderma only involves the skin. You do not see visceral involvement with localized scleroderma. Again, it is an autoimmunity. We think it has something to do with molecular mimicry. The sequence of events is that there's some T/B cell immune response that will typically cause some endothelial damage, and following that endothelial damage, fibroblasts get activated to control the damage, and the cytokine that activates fibroblasts is called TGF-beta. So again, one more time, you get an autoimmunity against endothelial cells. They make a lot of cytokines, one of which is TGF-beta. So there's an acute inflammation phase, and then that TGF-beta tells fibroblasts and also M2 macrophages that we need some collagen in there to patch up the leak, heal the wound, get some resolution to that acute inflammation, and then it shifts into the chronic stage. So endothelial cell damage, again, the big starting point for this pathology. Now, morphia, or limited scleroderma, it's only confined to the skin, starts off as an erythematous patch. And it's erythematous because it starts as an acute inflammation. And so with any inflammation, you get a little histamine, which is a vasodilator. And remember our rubor, dolor, Latin words for inflammation. Well, rubor means red, and it comes from histamine, because when you vasodilate everything, you've got an increased blood flow to that particular area. And the increased blood flow, you can kind of see through the skin, it'll be red. So that's your erythema. So after the acute inflammation resolves, then you're into the chronic stage, and these plaques will lose their red color and turn pale, tan, or yellow, and start to soften up. And at this point, the plaque itself, if you were to biopsy it, it's basically nothing but fibroblasts and collagen. So morphia is not the most difficult thing to recognize. It's always circumscribed, meaning it's always got margins or edges to it. And we can call it superficial or deep based on the extent of skin involvement. Circumscribed means it's epidermal and dermal. And then deep means it goes past the dermis into subcutaneous tissue. And even muscles and bones can get involved, even in a limited scleroderma. One type of, I suppose, common morphia is called linear morphia. that you often observe on the face. Now, let's take a look at a few pictures. Skip that. Here's some typical plaques of scleroderma. A couple on the back here. Again, notice that they are pretty well circumscribed. They're not diffuse. And here on this patient's legs, these plaques are a little shiny in color. They're definitely not red. So that clues you into this patient's had these for a while. They're in the chronic stage of their illness. Here's something called in coup de sabre. Essentially means a sword slice. And that's kind of what it looks like. If you were to take a sword to the face, you might come away with some sort of linear scar. As you see here, this is linear morphea. You could also have generalized morphea, defined by the presence of greater than 4 plaques that are all larger than 3 centimeters. And if you were to biopsy the skin again, you would see a gross excess of collagen and fibroblasts. So this is limited scleroderma in which there are no internal viscera involved, only the skin. Relevant lab studies, ESR and CRP will be up, which is how you'll know you ought to consult rheumatology, look for a systemic disease. Autoimmunities are certainly on the radar whenever ESR and CRP are up. And just in case you want to get more specific regarding the histology, you will see an inflammatory cell infiltrate in those earlier stages of these plaques, again, when they're red and erythematous. But as they kind of fizzle out and fibroblasts start to play their game, then the lymphocytes and plasma cells start to go away, and you see mainly fibroblasts and collagen inside the skin biopsy. So that is limited scleroderma in which only the skin is involved. Now let's talk about systemic sclerosis. And this is where we'll refer back to the vocabulary again, because I don't want you to get anything mixed up on a test. You can have limited or diffuse systemic scleroderma. So limited typically means that the periphery is definitely involved, and you might get some esophageal involvement as well, but you typically do not see internal organs involved that heavily in limited scleroderma, compared to diffuse systemic scleroderma, in which all bets are off. The heart, the lungs, the kidneys, vasculature all over the body may become involved in the fibrotic process, leading to potentially multi-system organ failure. So that's the big difference between diffuse and limited scleroderma. Let's check out some patient cases before we get into the text. Here's a 45-year-old woman with increased difficulty swallowing both solids and liquids during the past few weeks. Her history is significant for Raynaud phenomenon, dilated capillaries on her face, and thickened skin over her fingers. A barium swallow discloses dysmotility. So let's pick this apart. Remember that when we're working up dysphagia, which is trouble swallowing, you want to always make sure to ask, is it solids or both solids and liquids? Because if it's both solids and liquids, that indicates it's a little bit more severe of a pathology. Things like achalasia and scleroderma are then in your differential. You also want to make sure you ask duration of episodes. Does it come and go, or is it a pretty constant thing? Raynaud phenomenon, recall that that's going to be hypersensitivity to cold in the digital arteries. They like to vasospasm. When we say vasospasm, same thing as a Prinzmetal angina, right? You just get your capillaries go yeet, and they kind of bunch up together. And so that's essentially the same thing as a thrombus. It's an acute vaso-occlusion. And so in Raynaud phenomenon, your fingers turn white and then they turn blue as you start to, your fingers turn ischemic with the loss of that blood flow. And then when you go back inside and your hands get warmer again, they will turn red. So you'll go from white to red to blue to red. And that red is the reperfusion of those tissues. Dilated facial capillaries, our word for that is telangiectasias. And those can be due to a lot of things. They can be due to increased estrogen concentrations. So if you had cirrhosis, for example, you might be prone to developing some telangiectasias. There's also a hereditary telangiectasia disease called Osler-Weber-Rindu, in which you particularly get them on the mucous membranes as well. And that's correlated with GI polyps, recall. And then thickened skin over the fingers, that's a little vague, but they want to be like that in test questions. What you need to recognize is that this thickened skin on the fingers is indicative of calcinosis cutis typically. That's what they're trying to lead you to understand that is. And even if it's not the calcinosis, it's still scleroderma, thick skin. So you should be able to put one and one together there. So then the question is, what's the cause of this patient's symptoms? And you see a bunch of esophageal this and that's. So this question requires you to understand that scleroderma is going to affect the lower 2/3 of the esophagus, which are smooth muscle, as opposed to the upper 1/3 of the esophagus, which is striated muscle. One more question. A 36-year-old woman has a 2-month history of difficulty swallowing, dysphagia to solids but not to liquids, uncomfortable but not painful. Her hands are very sensitive to cold weather. Her vitals are A-OK. She's got thick and slightly edematous skin in the hands and 3 small subcutaneous nodules on the right forearm. Her thyroid is normal on palpation. What would you see on further evaluation? So here's where they give you many antibodies, because again, scleroderma is an autoimmune disease. So there are some characteristic antibodies when you work up the blood. And you can go ahead and cross everything off of this list that does not have to do with scleroderma, because this is, again, a pretty classic constellation of symptoms here in this stem. You can get P-onca off the list. That would be our pulmonary renal syndromes. IgM anti-IgG, what's that? That's rheumatoid factor, right? IgM against IgG. Anti-Smith, no, that's lupus. Anti-La, no, I believe that's dermatomyositis. So then you're left with 2 different answer choices that are both found in scleroderma. And what this question requires you to know is that one of them is more common in diffuse scleroderma. The other one is more common in limited scleroderma. So the answer to this question is anti-centromere antibodies, or what you would expect in the bloodstream, because this patient has nothing in her presentation to lead you to believe that she has major visceral involvement. The esophagus is involved, but there's no lung problems, there's no renal problems, there's no cardiac problems in this stem. So you have to assume that she has limited and not diffuse scleroderma. So again, one more time, going back to this good graphic, limited means peripheries, yeah, they're involved. So that's why she's got nodules on her hands. That's why she's got Raynaud. And esophagus can be involved in limited, but diffuse means you're taking a big jump into pulmonary involvement, renal involvement, etc., on down the line. So understand limited versus diffuse, because there is a different characteristic blood antibody for each one of those. In diffuse scleroderma, the most prevalent antibody in the blood is going to be this anti-SCL70, SCL for scleroderma, which is also an anti-DNA topoisomerase 1 antibody, versus in limited scleroderma, which is synonymous with Crest syndrome, you tend to see anti-centromere antibodies. So knowing the difference between the antibodies in the different categories of scleroderma is important. Getting back to the text, systemic sclerosis, again, we will call this diffuse or cutaneous. Now, very, very rarely there's this third type called scleroderma, sign scleroderma, and you could probably figure that out on your own. That means you've got kind of the esophageal presentation, maybe some of the lung or kidney problems. You've got your internal organs. They have scleroderma, but you have nothing on your skin. So it's without the scleroderma, literally. So it's still a collagen problem, still an autoimmunity, still a chronic disease, but the skin is not involved in that scleroderma, sign scleroderma. That's about all we have to say about that. Again, understand there are 2 big types of systemic sclerosis. There's diffuse, in which the skin is involved, you betcha, but internal organs are also commonly involved in diffuse scleroderma, versus limited scleroderma, in which the skin is always involved distally, working its way proximally, but there is a prolonged delay in the appearance of distinctive internal manifestations. So the patients can have the Raynaud and the calcinosis and the esophageal problems a decade plus before they see any of the pulmonary or renal ramifications of this disorder. CREST syndrome is a handy mnemonic that's going to stand for calcinosis, Raynaud, esophageal dysmotility, scleroderma, so those skin nodules, and telangiectasias. And CREST syndrome is virtually synonymous with limited scleroderma. Now, they're not exactly the same. I would think of it as all patients with CREST syndrome have limited scleroderma, but not all patients with limited scleroderma develop the full range of CREST syndrome. Let's get into some symptoms. How do these patients present? Well, this is an autoimmune endothelial damaging disease, so it's going to give you a vasculopathy. It's a T cell, B cell response against something on endothelial surfaces, okay? And then endothelial cells make cytokines that activate fibroblasts. But because endothelial cells are involved, you see vascular symptoms. So Raynaud phenomenon, again, that's a vasospasm that indicates vascular damage. It's a blood vessel problem. So quickly looking at Raynaud, fingertips first, always the fingertips, because those are going to be the smallest arterioles, your digital arterioles. And recall the white to blue to red presentation, where first they get a little hypoperfused, and then they totally turn blue as they turn ischemic, and then they get some blood flow back to them, and your fingers will turn bright red as they get reperfused. And really interesting, actually, a couple of studies followed large cohorts of patients diagnosed with primary Raynaud's, and they found that upwards of 10% of patients diagnosed with Raynaud in both cohorts ended up developing some form of scleroderma. So there is a noteworthy correlation of scleroderma with Raynaud. Other symptoms, tight skin. Again, there's collagen inside the skin. And if we look at some of this histology, it's obvious. Because there's so much collagen inside the skin, here's a good example on the right. Because there's so much collagen, the skin becomes fairly rigid and inflexible. And so it's kind of like free Botox, you know, you should pitch it to your patient that way. Like, hey, okay, you look pretty young now. Your skin's all nice and tight, no wrinkles. But the thing is, you look under the epidermis and it's nothing but collagen in the dermis. And so tight skin on the face, on the hands, characteristic symptom of systemic sclerosis. Digital and facial telangiectasias gets brought up on page 6 here. And then it goes on to say that vascular alterations are seen in virtually every organ affected by systemic sclerosis. So those telangiectasias, if you were to do an EGD, you know, which is a pretty good first step at diagnosing some sort of esophageal dysmotility or maybe a gastroparesis that these patients can get, if you were to do an EGD and look inside the proximal GI tract, you may see telangiectasias lining the mucosa of the oral cavity and esophagus. Then there's calcinosis cutis, gets brought up here also on page 6. That's something that you definitely have to know. And when we say calcinosis cutis, we mean there's calcium in the fingertips, cutis. That's essentially the area that's talking about like the cuticles of your fingers. So it's so much calcium that if you were to do an x-ray on these patients, you literally see the calcium deposits inside their hands. And so they'll present as these tan white nodules, just clearly discolored compared to the surrounding skin. And they will be pretty tough as a rock. You know, it's literally calcium in there. So if you get shown a patient with this sort of symptom, for step 1, scleroderma is about the only thing that's going to cause this digital presentation. That's calcinosis cutis. Again, the capillaries are damaged in this disease because it's an autoimmunity against endothelial cells. How could the capillaries not be damaged? And that's kind of the first step in the pathogenesis. And after that endothelial damage, the influx of cytokines into the surrounding extracellular fluid activates fibroblasts. You get some TGF beta action, and there is going to be your collagen deposition leading to the scleroderma. Now, normally Raynaud does not get that bad, but in the case of systemic sclerosis, Raynaud, if you're left out in the cold too long, can lead to ischemic digital ulceration, kind of similar to this vasculopathy that smokers get. You remember the one that I'm talking about, typically men, and they'll be in their 30s or 40s, and they'll have like a 20-year pack history. And one day they'll look down and their fingers are turning gangrenous and dark, ischemic. And that's called Weger's disease, right? Not to be confused with Berger's disease, which is an IgA nephropathy. No, that's called Weger's disease. It's the distal digital vasculitis that smokers get, and it causes ulcerations of the fingers. And so you see something similar in scleroderma, where whenever the Raynaud gets activated by the cold, because these blood vessels are surrounded by collagen, they're very easy to damage. And you can get ischemic very quickly if they vasospasm and occlude themselves, because oxygen has to diffuse through all the collagen that's around these vessels to get to any functional tissue. And so the more collagen there is, the farther oxygen has to hike to get to where it wants to go. So more collagen, more ischemia, eventually can lead to ulceration, tissue death. GI involvement in scleroderma is absolutely testable. Typically, it's the esophagus that they want to ask you about, and it's esophageal motility studies compared to other diagnoses. Let's peep that quickly. So in scleroderma, the concept is that the smooth muscle of the esophagus is affected by fibrosis, but not the upper 1/3 of the esophagus, which is skeletal muscle. So you'll look at a manometry tracing. Manometry is measurement of pressure. You'll look at this for the esophagus and you'll see that the upper esophagus is totally cool. But then as soon as you get to that middle esophagus, pressure stays low, really low in there. And food is not going to get down. You're not going to have peristalsis in the middle and lower esophagus. That's what the small little bump. You see how this bump is very small compared to the wave that you see on a normal manometry? Well, that little wave is small because there's no peristalsis. Why is there no peristalsis? Because the esophagus is turning into basically a lead pipe with collagen encasing it, coating it. So it's very tough for that smooth muscle to contract properly when it's stiffened by the deposition of collagen around it. So that's scleroderma. You'll see a lower esophageal sphincter pressure that will help you set it apart from achalasia, which is one column rightward here. Look at this. This is important. In achalasia, what's the pathogenesis? Well, it's going to be damage to the nerves that tell your lower esophageal sphincter to relax with mediators such as nitric oxide and VIP. And if you start losing those neurons, typically autoimmunity, post-infectious, then you get achalasia. And again, the hallmark of achalasia is that you can't relax that lower esophageal sphincter. But in scleroderma, you have no problem getting that sphincter to relax because there's nothing wrong with the neurons. It's just solely a collagen thing. So that LES pressure differentiates achalasia versus scleroderma. Because you have an esophageal problem, well, when you have an esophageal problem, you are more prone to develop gastric problems, delayed emptying, Gastroparesis is what we call that, you know. So you might diagnose gastroparesis and then the patient shows up half a year later, and they've got these bumps on their hands. That's an example of when you would be very suspect of scleroderma. Start working them up farther for that. So gastroparesis is, again, just delayed emptying, and it's a little bit in part due to the fact that food is delayed getting into the stomach from the esophagus. So if it takes longer to get into the stomach, it's going to take longer to get out of the stomach. That's simple. And again, you might see telangiectasias in the mucosa of the stomach if you were to stick a scope down there. So don't be surprised by that. Have scleroderma in your differential. So up until now, let's time out. Up until now, all the symptoms we've talked about: Raynaud, calcinosis cutis, esophageal dysmotility, those can be found in limited scleroderma, and they can also be found in diffuse scleroderma. But now we're going to start talking about a bunch of internal viscera symptoms that are solely characteristic of diffuse scleroderma. Okay, so when you start seeing something like pulmonary involvement, renal involvement, now we are in diffuse scleroderma territory. So how do the lungs get involved? Well, it's a chronic autoimmune disease that damages endothelial cells, activates fibroblasts, and throws down collagen. So that happens in the lungs, and when you get a lot of collagen in the lungs, you get a restrictive lung disease, pulmonary fibrosis. And recall that in a restrictive lung disease, it's really tough to get air into the lungs compared to an obstructive disease in which, yeah, you can get air in the lungs all day, but you can't get air out of the lungs. So scleroderma gives you pulmonary fibrosis with a restrictive pattern in which every single lung volume will be down. And one thing's going to be up. And remember, it's going to be that FEV1 FVC ratio, right? Maybe it's FVC, FEV1. I think it's FEV1 FVC. But that ratio, recall, goes up in a restrictive lung disease because it's measuring how quickly air moves out your lungs. And if you have a restrictive pulmonary pattern, air wants to leave your lungs. It is sprinting out of your lungs because, again, there's collagen in this case, encasing your lungs, squeezing the air out of it with its tensile force. So if you were to look at a chest x-ray of a patient with scleroderma who has developed pulmonary fibrosis, you would see a couple of things. Namely, you would see patchy interstitial lung fibrosis that would present as ground glass opacities in a peripheral distribution. That's the sort of thing I'll take a quick note on in first aid just to remind myself what the pulmonary presentation of scleroderma looks like. And recall, this is a disease with an acute phase that quickly burns out and puts you into a chronic phase that lasts a lot longer. If you were to biopsy the lung in this acute phase, of course you'd see lymphocytes and plasma cells. It's an autoimmunity. And there's inflammation, so there's immune cells in there. That's what inflammation means. But then if you biopsy it later on in the chronic course of the disease, you would see thickening of the alveolar wall with just about nothing around but collagen, type 1 and type 2 collagen, and no inflammatory cells on the scene because all that TGF beta, the acute response, has burned out. You're now in the chronic phase laying down collagen. So if that can happen around the alveoli, you better bet it can happen around the pulmonary arteries and veins too, which can give you a pulmonary hypertension. Same thing as is happening in the Raynaud syndrome in a scleroderma patient. You've got these arteries or vessels and they get damaged. There's some endothelial damage. So you throw down collagen around the arteries and that turns them into lead pipes and they can't expand and compress. They can't fluctuate according to the flow of blood through the area. So that's the pulmonary hypertension. They're pretty easy to understand, I think. You see intimal fibrosis. Recall that your large arteries have an intima, a media, and an adventitia. So you would see fibrosis of the intima and the adventitia in this setting. And then you would see some medial hyperplasia as well. Again, that's going to be reactive to the endothelial damage, similar to atherosclerosis. Similar to how those fibroblasts are reacting to the endothelial damage. Well, that's what connective tissue does, and smooth muscle is a type of connective tissue. So that's why there's medial hyperplasia. These smooth myocytes within large arteries are reacting to the endothelial damage. Let's talk about renal involvement in scleroderma. You have to be cognizant of what's called scleroderma renal crisis. And anytime you see that word crisis, you know that things are getting very bad, very fast. So recall our measurements of kidney health. First, there's urinalysis. What can we get from a urinalysis? Well, you can see protein and you can see red blood cells in the urine. And so that can lead you to a nephritic diagnosis. And then there's also serum BUN and creatinine. And that's a great measure of kidney function as well. So those are the sorts of labs you should expect in a question if they're trying to guide you to a scleroderma renal involvement. Okay, let's get specific here. The glomerulus gets involved. The interlobular arteries going into the glomerulus get involved. So when there's collagen around the arteries of the glomerulus, they can't fluctuate or vasomodulate in response to increased blood flow. So what that means is that they're going to be damaged. And when you damage glomerular arteries, your blood pressure goes up because they're going to be less capable of filtering. So that can lead to treatment-resistant hypertension, malignant hypertension. And that glomerular damage over time can present as acute renal failure, in which the patient's going to produce less and less and less urine gradually as more and more glomeruli lose their filtering capacity due to this collagen damage. We want to give these patients an ACE inhibitor to dilate the efferent, because if the glomerulus itself is really skinny, that's a high pressure zone. So the more we dilate the efferent, the lower pressure we make that, the more we can get some blood out of the glomerulus and stop it from trying to just shove itself through all the collagen around those glomerular capillaries, which is only going to make things worse. So we really want to get this patient's GFR down, because the longer it remains up, the more glomerular damage there is. How can the heart get involved in scleroderma? Well, same principle. You've got arteries, they've got a bunch of collagen around them, and there's endothelial damage. So that can predispose you to vasospasm, same thing that's going on in the Raynaud, distally, vasospasm of digital arteries. We could get that on a coronary artery. That's really bad. That's virtually the same thing as Prinz metalangina. So that's how the heart can get involved in systemic sclerosis. Arthralgias, also common. Contractures, also common against scleroderma. And peripheral neuropathies have been observed in a minority of patients, usually carpal tunnel syndrome due to compression of the median nerve right there. The more collagen gets thrown down right there, the more entrapped that median nerve becomes. Remember, you can do one of those tapping. I think that's Tinel's sign. You can have them do one of those tests, and that'll be your diagnosis for median nerve entrapment. And one more thing, if that carpal tunnel's been going on for a long time, the median nerve innervates the, let me see here, lateral palm, because the ulnar nerve innervates the pinky and this side of the fourth digit. So that's technically your medial palm, right? So the thenar eminence, that's on your lateral palm, that'll be atrophied in a long-standing carpal tunnel syndrome because the median nerve, its signal to the hand, is being reduced. Here's some talk about antibodies. Let's be real simple about this. If you see anti-topoisomerase 1 antibodies, or maybe they're called anti-SCL70, you know that that is virtually synonymous with diffuse systemic sclerosis. Likewise, if a different answer choice in the same question is anti-centromere antibodies, you know that these ACAs are referring to a patient with limited systemic sclerosis. One more time, what's the difference here? Limited, that's your CREST syndrome, right? That's your calcinosis cutis, your Raynaud, your esophageal dysmotility, your scleroderma, as always, and your telangiectasias, which commonly appear on the face and hands. So there's no viscera involved in a limited systemic scleroderma, and you would expect to see anti-centromere antibodies. Versus this patient comes in, dyspnea on exertion, anuria, proteinuria. Then you're thinking not limited, but diffuse systemic sclerosis, which characteristically shows anti-SCL70 antibodies, also known as anti-topoisomerase 1. So that's how that'll get posed to you in some sort of test question. Here it is in the chart. Anti-centromere, limited, anti-topoisomerase, diffuse. Now, the third type is a little more rare than the first two. I still think you want to recognize it for this upcoming path exam. They're anti-RNA polymerase 3 antibodies. And what I noticed was standout was that they are strongly associated with scleroderma renal crisis. That's about the only thing I got. Again, they're going to be for a diffuse, not a limited scleroderma, but maybe, just maybe, they ask you the question and anti-SCL70 isn't an answer choice, but then anti-RNA polymerase 3 is. And so you would have to recall that that is also associated with diffuse systemic sclerosis. Now let's talk about Nailfold capillary abnormalities. To my knowledge, there is not another disease in first aid that is associated with these giant capillaries on the dorsal side of the nail bed. Let's take a look at them on a patient, then let's talk about how we get there. This is a patient who's had little black arrows tattooed onto their finger. I think this is post-Malone. No, I'm kidding. This is a patient, those arrows are pointing to capillaries. They're called Nailfold capillaries because once you know it, they're right next to where the nail folds into the skin. So you can literally see them with your naked eye. And that's really bad because they're capillaries, they ought to be a lot smaller than that. So when you see something like this, what you're going to do is you're going to take out some normal oil that you would use for a microscope slide, and you're going to drop it straight on this patient's finger, and then you're going to take your microscope and just look at the patient's finger as if it were a slide. And that's how you perform Nailfold capillary microscopy. You don't do a biopsy, you just straight up look at the patient's finger. And when you look at it, you will notice giant capillaries, and they're going to be big and swollen up because that's what happens whenever you got a lot of collagen around one little section of a capillary bed. Everything upstream to it is going to have higher pressure because that collagen is like a pseudo obstruction. It's a bottleneck. Flow has a tough time getting through that sclerotic section of artery. And so again, flow builds up upstream. There's your aneurysm, microaneurysm, and eventually a microhemorrhage. So those are the giant capillaries. You know that this is a collagen vascular disorder. And there are different stages that you might want to know. You might see a test question about this. Let's point out the 3 stages. First, there's the nail folds that you can see in early scleroderma, in which you see giant capillaries and microhemorrhages. Okay, so normal nails, you don't see any of that. Early scleroderma, microhemorrhages, and giant capillaries. Now, in active scleroderma, you start to see the loss of capillaries. So maybe a reduced quantity or straight up number of capillaries compared to control when you look at it under a microscope. Then finally, in the late scleroderma pattern, you do not see giant capillaries or microhemorrhages. That's already happened. That's past tense. Instead, you see neoangiogenesis mediated by VEGF. So something very similar to what happens to the eyes in a diabetic retinopathy, a high degree of neoangiogenesis, right, in a wet retinopathy, with a lot of the hemorrhages preceding that neoangiogenesis, creating ischemia and thus the need for vascularization. Let's talk about something else I think is particularly testable. You lose the Rete ridges in the skin, and they might want to say, what do you see on the skin biopsy of this patient in scleroderma? You know, it's not a tough question. But it's something that you have to know the particular answer to. So what are Rete ridges and why do you lose them? Let's look at some photos. Rete ridges are going to be these little wavy things, like they're undulating. That's how I would describe them, like the brucellosis sketchy with the hills, with the undulating fever. That's exactly what Rete ridges or Rete pegs look like. And they're going to be little sections of the epidermis that's on the top of this photo that just protrude down into the dermis, which is the more pale pastel pink at the bottom of this photo. So those are Rete ridges, and in scleroderma, you lose them. So the epidermis relative to the dermis is totally flat, and this looks like train tracks instead of an undulating hill, you know? So less like a waveform, more like a straight line. That's the loss of Rete ridges that you see on biopsy. Why do you lose them? My suspicion is that, again, taut skin. Why? Because there's collagen underneath the epidermis. Inside the dermis, there's so much collagen that it's expanding the epidermis and flattening it out, okay? Like if you had a string or a piece of paper, you know? Let's take this, right? I could take this towel and I could hold it and it doesn't have a lot of slack on it, but I could pull it tight and now it's straight. So that's the loss of Rete ridges. You're just pulling that epidermal layer straight as the pressure underneath it builds up and pulls it taut. That collagen has a tensile force. Telangiectasias, we mentioned that. Face, hands, mucous membrane, can be lips. Here's some photos. They can be very, very small. You got to be attentive to detail to pick up on these. Here's, again, calcinosis. They're going to be little rock hard nodules inside the skin. They chiefly occur in the fingers. They can be found in the olecranon bursa right there, you know, the olecranon process of the ulna. You could find them in the knee, just about anywhere in the body. And these little calcium deposits can get infected. And if they do get infected, you might see a draining fistula or a sinus. We're talking about the same sort of draining sinus that is characteristic of actinomyces infection. Recall, you've got those draining sinuses in the jaw because that's where you typically get the bug following some sort of dental procedure, treatment penicillin. Then we go on to talk about the etiology of systemic sclerosis. And guys, let me tell you, whenever it says in the SDL, the etiology is unknown, what I say is, all right, if they ask us anything about this, it's going to be one question and it's going to be relatively easy. So you don't really need to harp on the etiology of systemic sclerosis. If the professionals who write the material straight up tell you, we kind of think we know what's going on, but we're not sure. So symptoms, yeah, heavily testable. Physiology, absolutely know your esophageal manometry, but again, etiology, not so much. So there's an HLA-DQA1. Again, we think that's associated. We're not sure. Some molecular mimicry might be the instigating stimulus for the autoimmunity. T's and B cells are going to attack endothelial cells, and that endothelial damage activates fibroblasts. There's your calcium deposition. There's your fibrosis. There's your scleroderma. Here it is in the text. Vascular and endothelial cell changes appear to precede other features of systemic scleroderma. The event that initiates vascular injury is currently unknown. However, cytotoxic T cells, autoantibodies, infectious agents have all been implicated. So again, there is an immunologic component, which is why these different scleroderma skin plaques are red at first, but then they quickly again turn pale as they burn out and go into a chronic phase in which fibroblasts get activated. That's your typical wound healing process with TGF beta, and collagen gets thrown everywhere. So that's our best understanding of the etiology of scleroderma. How do we treat it? Well, whenever it's multi-system, we're going to have to treat multiple systems. For early stages of the disease in which it's still inflammatory, immunosuppressants seem to do an all right job. Methotrexate, a dihydrofolate reductase inhibitor, and also mycophenolate mofetil, which is going to stop cells from making GMP. Then to treat the esophageal and gastric issues, we rely on proton pump inhibitors, so omeprazole frontline. Calcium channel blockers is actually what we use for any Raynaud, not just scleroderma-associated Raynaud. But again, there's a big association between Raynaud and developing later down the line sclerosis, so we use the same drug. That's going to just dilate arterioles. And then ACE inhibitors for renal crisis. Again, remember the glomerulus has collagen all around it, so it's a high pressure zone. It's really tough to force blood through all that collagen through the GBM into the tubule, so that damages the GBM, those high pressures. So we want to dilate the efferent to take some stress off of the glomerular capillary bed. And that's about all we have on scleroderma. Thanks very much.